Good morning, everyone, and welcome to the Kangos Memorial Lecture. This lecture is held annually, and it's in honor of Jim Kangos, pictured on the slide above. Jim Kangos received his undergraduate education at Bucknell University and his medical education at Rutgers Medical School and later Tufts University School of Medicine. He was resident in pediatrics and later on became the outpatient chief resident at UPMC Children's Hospital from 1977 to 81. Thereafter, training in Pittsburgh, he was engaged in private practice in Connecticut until 1986, when tragically he died before his 35th birthday due to complications from ulcerative colitis. During his brief career, he championed the cause of foster children and worked effectively to reform regulations governing the disadvantaged group for which he had a special affinity. He was born to a close and nurturing family, and with his wife, Vicky, perpetuated a tradition of family values that they instilled in their children, Edward, Allison, and Michelle. Jim wore a constant and warm smile and laughed when he faced uncertainty. He laughed with unstudied and unstinted joy. He bore frequent pain privately with quiet grace, faced uncertainty with optimistic confidence, and confronted his too early terminal struggle with uncommon courage and characteristic concern for others. It was Jim's wish that this annual lectureship be established at Children's Hospital of Pittsburgh of UPMC to stimulate future physicians to study and ultimately control inflammatory bowel disease so that some good might come of his ordeal. He left money for this purpose, which funds donated by his family and friends will perpetually support this worthy goal and honor the memory of a deeply missed colleague and cherished friend. I know that Dr. Kangos' relatives are online this morning, and I wish them well and wanted to say hi personally. Our speaker today is Whitney Sunseri. She is a native Pittsburgher and board-certified gastroenterologist. She, despite being born in Pittsburgh, she defected to Penn State and got her degree in life science, and this was somewhat willingly. This was very willingly. She really enjoyed her time at Penn State. She then went on to University of Illinois at Rockford to complete her medical training, and then came back to Pittsburgh for residency and fellowship, where I first met her in 2011, I believe. She is now an assistant professor at pediatrics and division of gastroenterology at the University of Pittsburgh School of Medicine. And she since she has been here, she served as the assistant program director for the pediatric GI fellowship program until 2023. And she is still serving as the APP fellowship program director until Friday. She became the director of the IBD Center here in Pittsburgh in 2003. And in this role, she brings both an energy and a work ethic that really puts the IBD Center in a position of growth. I'm excited to see a lot of the great things come from this center as time goes on, as this program continues to grow. And with that, I'm going to have Whitney come up and tell you a little bit about what's going on with the program and see how and introduce you to the IBD Center here at Pittsburgh in 2025.
All right. Well, thank you, Jeff, and thank you all for being here today. I'm really excited to talk about our IBD Center here at Children's Hospital. And before I start, I want to say a special thank you to the Kangos family. I'm really was lucky enough this week to hear some stories about Jim from one of my colleagues, Leslie Coda, and it was very clear that he was a remarkable young man. I'm honored to be able to give this lecture in his stead today. I am a key opinion leader for Cape Farms. I lied here a little. I do have another disclosure. I am insanely passionate about what I do every day, so I am going to probably go a little long in these lectures, so I'll do my best to be timely. Additionally, I just wanted to highlight that I'm surrounded by insanely dedicated and enthusiastic people every day. Our team is made up of individuals who go above and beyond for our patients, and without them, none of this would be possible. So I really wanted to say a special thank you to our entire IBD team. All right, so today we're going to go over, do a little bit of an IBD overview, talk about our IBD Center and the care models we're putting in place, along with future technology that's coming out in regards to diagnostic and our future goals for our program. All right, so what is inflammatory bowel disease? We think about inflammatory bowel disease in general as a chronic inflammatory disease with relapsing and remitting inflammation. And we think about it in two kind of buckets of phenotype or activity, either Crohn's disease or ulcerative colitis. In reality, it's probably a spectrum of different disease processes that have a phenotype of inflammation, such as Crohn's disease, affecting anywhere from the mouth to the anus, with complications of stricturing disease, penetrating disease, and perianal complications. And then we also talk about ulcerative colitis being a superficial inflammation starting in the rectum, moving in a contiguous fashion, more proximal throughout the colon. However, just to make things interesting in pediatrics, we also have a third phenotype that we talk about as indeterminate colitis. And this happens to be because our children under the age of 6, which we call very early onset IBD, Crohn's disease has an affinity for the colon and oftentimes shows up as a pancolitis that's indiscernible from other ulcerative colitis. And so oftentimes we have to give this disclaimer to our pediatric patients that we really don't know whether or not they're going to eventually have Crohn's or ulcerative colitis. But at that time, we typically treat them the same. And so what causes IBD? We talk a lot about polygenic gene mutations and monogenic gene mutations. Monogenic is more of a one-hit type of pathology, which is rare, but we see it in our very early onset kids. And when we talk about polygenic gene mutations, we have about 150 to 200 genes that have been identified, depending on the literature you're looking at. And so I could be walking around with one of those gene mutations today and never go on to ever develop inflammatory bowel disease. So it's really a two-hit system for most of our population. And what that other hit can be a combination of health-related aspects, lifestyle factors, or environment. So if you live in a rural environment and spend a lot of time in green space or blue space, we call being by water, that's protective. Having a dog is protective, which one of my families is not thrilled. I told their child they have a golden doodle now. Lifestyle, whether or not you were breastfed as a kid, what kind of diet you're on. Are you eating whole foods, or are you eating a lot of preservatives and emulsifiers that are breaking down the mucus barrier? Are you physically active? What infections you've had as a kid, things that we have no control over, right? How many bacterial infections you have and have to go on antibiotics. And if you've been on broad spectrum or narrow spectrum, whether or not you've had an helminth infection and had to be on anti-helminth therapy. So all of this really plays a role to make a perfect storm, which causes an upregulated immune response that's inappropriate. Your body's trying to fight off an infection that's not there. And as you can see, and I don't expect you to really see all the granular detail there, but it's a very heterogeneous response. So there's not just one immune cytokine or cytokine pathway that's causing this upregulation. So again, just highlighting that it's more of a spectrum of disease. And so pediatric IBD is not just treating little adults. We are very different, and our patients have a very different phenotype. Just knowing that patients are diagnosed under the age of 18, they typically have more severe disease with more complications. As you can see on this pictorial up here, the top part being Crohn's disease, the majority of our patients fall into the L2 or L3, meaning they have extensive colonic involvement or ileocolonic involvement. And then on the bottom, you can see that the E3 and E4, kind of describing the distribution of our ulcerative colitis patients, are approximately, I wouldn't say it was 90 or 86%, are using about 2/3 of their colon, or it's affecting the entire colon. With our kids under the age of 6, it goes as high as 96% of kids have a significant disease burden. Additionally, they're having a longer disease burden. So these kids are being diagnosed earlier and earlier, as I'm going to highlight that our very early onset IBD kids are the ones who are increasing in incidence at the fastest rate. Additionally, we're having better therapeutics, and so they're living longer. So our patients are having a longer duration of having disease. In addition, the longer we have disease, the more likely we're going to have complications from disease. Additionally, the more medications we're exposed to for longer periods of time. So having complications from those medications, such as non-melanotic skin cancers, possible lymphoma, and other complications associated with that. And as pediatricians, we're in a unique position to make sure that we're paying attention to that fifth vital sign, our growth curve. A lot of our kids are being diagnosed under the age of 12. So that means this is before puberty. And so we have to make sure that we're getting them under good control quickly and effectively and keeping them under good control so they can reach their genetic potential. And then I do have here highlighted the Paris classification that just really highlights that one of the characteristics as we think about our patients is whether or not they've experienced any growth delay. We also know that our patients have a higher incidence of psychological stress. The prevalence of anxiety in our patients is about 32%, and that is higher than their age-matched peers. And depression, about a quarter of our kids are suffering from depression, and that increases to 50% and 30% respectively for anxiety and depression when they're in a flare. This does not account for the increase in body dysmorphism that they're experiencing, disordered eating, medical PTSD, and significant needle phobia that they are having at higher rates than their age-matched peers. Additionally, we know patients with IBD with a comorbid mental health diagnosis increases risk for ER visits, inpatient hospital stay, and accrue higher surgical, medical, and pharmacology costs compared to patients with IBD alone. So it's really imperative that we focus on their behavioral health as well. Additionally, there has been a surge in the amount of drugs that we have. But however, as we know, pediatric medications and research has really lagged behind the adult world. And so we always have about a 10-year delay before our medications, and maybe even longer than that, before our medications are approved and we're able to use those. So most of the medications we're using on a day-to-day basis are used off-label. And by the time I order that medication and it gets denied and we do our peer-to-peer, from the time I place that order to the time it actually reaches the patient is at least 2 weeks, if not longer. And if you think about that, that's unacceptable if you were treating a pneumonia or any other disease process. So we have to do better. And then, as I already mentioned, our pediatric patients are the group that are increasing in incidence, and they're increasing very rapidly, especially those under the age of 6. So this isn't going anywhere anytime soon. And if anything, it's it's a call to arms. Right now, we're seeing increased incidence across the world, with about 7 million people living with inflammatory bowel disease. And in areas that we've never even seen IBD before, it's increasing in incidence at the fastest rate. There's a lot of thought as to why that's happening, whether that's westernization of the diet with more preservatives and emulsifiers, color dyes, whether it's industrialization of those areas, or is it that we're having better identification? Probably a combination of all factors, right? They're in those areas now, we have gastroenterologists, and there's access to endoscopy and better identification and treatment. In America, we're living, about 2.4 people are living with inflammatory bowel disease, of which 25 to 30% are diagnosed under the age of 30. So again, we're going to see a lot of these kids, and it's important that we really prioritize their care. In America, though, we are seeing something called compounding prevalence in the adult world. So the adult world really has had a stabilization of incidence since 2016 that they're seeing in a recent study. And we're seeing lower mortality because we're treating these kids and these adults better, and they're living longer. So the amount of Americans are still growing, but every year about the same incidence is seen in the adult world. And that's in part due to the explosion of medications that we've had. And I don't want to bog you down by all of the slide here, but really it's just trying to pictorially highlight the fact that we've had a rapid evolution in new medications. And our medications are becoming more targeted. So you're having less side effects. There's less immunogenicity, and there's less less side effects. But the problem is that none of them are really approved yet in pediatrics. All of the medications that we now talk about that we're trying to avoid, such as steroids and 5-ASAs in our patients with Crohn's disease, they're one of the only 2 that are really approved. We have infliximab and adalimumab as our biologics that are approved by the FDA. However, all of the new therapeutics, which I use on a daily basis, are not approved. And there's a paucity of research done so far, and we need to do better, move that needle forward so we can continue to take care of our kids in an appropriate timeline. So you could imagine, Charlie Day, he's my favorite. So you could imagine the amount of angst this provides a gastroenterologist. And if you're doing anything but focusing on IBD, it's almost impossible to keep up with the way that our therapeutics are evolving. And it would be difficult to do a good job in order to keep up and take good care of our kids, if you're trying to focus on any other endeavor. And so really it has necessitated sub-specialized care. That's right, 2 subs. So really, in general, how do we take better care of these kids? And over again, consistency is key, making sure that they're having a consistent provider, that we have an IBD nurse that is taking care of these kids day in and day out with consistent exposure to the new pharmacologic interventions that we have, so they know what side effects to look for and what triage to do. And then the families have a consistent voice on the other end, that we're giving consistent messages about how we're taking care of kids and what we want them eating and what diets. that we're coordinating that care, right? Life is busy. Most parents and most families have 2 working parents, and you have to miss work to go take your kid to the doctor. And so we have to have a comprehensive approach to how we're treating these kids if we want them to see the other providers that are necessary, such as a dietitian, a behavioral health specialist. And so we do need to coordinate that. We are lucky now to have 2 IBD nurse coordinators who are able to help families get coordinated visits, making sure that they're seeing their recommended providers for their extraintestinal manifestations. And it's imperative that we stay on the cutting edge of technology, staying up to date on these therapeutics, and looking to the future as to what's coming down the pipeline in regards to diagnostics. So I am going to talk a little bit about bowel ultrasound. All right, and all of this knowing that this is going to be what's important for our patients, really forced us to look at our center and know that we did need to reconstruct it just a little bit. I have the luxury of standing on the shoulders of giants here at Children's Hospital of Pittsburgh. Dr. David Kellyo and Dr. Sandy Kim really did a wonderful job of putting our IBD Center on the map. They were nationally known and have brought a lot of recognition to our program. That being said, our center was really an IBD center in name and not so much by structure. And I don't mean that in a derogatory sense. I mean that in the sense that all gastroenterologists were seeing IBD, but back when that was going on, there was only a handful of medicines that we were using. As you saw, that we really have evolved in seeing a lot more of these therapeutics, necessitating it to be structured down to IBD-oriented providers, in addition to IBD-oriented nurses. And so really, we needed to make a subspecialized clinic within the gastroenterology team. And so I'm going to go into a little bit about our IBD Center, who makes that up, because that truly is the magic and the sauce in the recipe. In regards to our care models, what we're doing along with emerging technology, specifically bowel ultrasound, and the future goals for our team. I wanted to take a second to welcome Dr. Erin Crawford, who has joined us as of Monday. She trained here at Children's Hospital of Pittsburgh. She's a phenomenal provider, and we're really excited to have her join our team just this Monday. And she's going to be an IBD-oriented, yeah, get it up. Hey, girl. All right. And so Erin, in addition to myself, are going to be 2 of our IBD-oriented providers, seeing the majority of our patients. Additionally, we're really excited that Nicole Davidson is going to be finishing up her fellowship at Nationwide Children's with our very own Hillary Michael. And she's going to be starting with us in September of 2025. So we now will have 3 IBD-oriented providers, and it's going to really improve access for our patients, continuity of care, along with the fact that we can also serve as second opinions internally and externally, and we'll have multiple different voices and thoughts and styles going through our patients when we're talking about them in IBD rounds. One of the things we do is every single Friday at 3 o'clock, we talk about all the different patients that we are seeing on the inpatient rounds, and making sure that we have a lot of other people thinking about our medically complex kids and giving recommendations. Additionally, we're going to be tasked with making sure that our faculty, when we come back from Advances in IBD or any of our conferences, that we're disseminating what's new and what's going on and keeping everybody else abreast of and educated. I also wanted to introduce you to Savannah Buhite and Kristen Veltri. They're our IBD dedicated nurses. This has never happened before, and this is a new phenomenon in the last year for our IBD team. And so now when our patients call, they are talking to somebody who specializes in IBD and only takes care of patients living with either Crohn's or ulcerative colitis. And we're assigned a nurse, so each physician has a specified nurse, but if there is cross cover, it's the same person instead of a pool of nurses and everybody chipping in. There's continuity in that relationship for those patient families, and they feel comfortable that this is a voice they've heard before on the other end of the line when their child is feeling unwell. Additionally, Whitney Gray is our nurse practitioner. She's been a cornerstone of our center since 2016. She has really spearheaded our transition and transfer program and does all of the new diagnosis teaching for all of our kids, along with the transition readiness education. And more recently in the last year has started seeing our patients ages 6 to 11 for a health maintenance visit. It's really important because most of our kids are on immunosuppression, and there's new emerging vaccination schedules, recommendations as far as what we should be doing for surveillance. And so she really helps all of us stay on target and takes the extra time in that visit to go over those things with the family. She also has opened up her clinic to do acute visits for our IBD patients. So when the providers are on the inpatient service and one of their patients is flaring, You don't just reflexively send them to the ER. If they're spot on Whitney's schedule, she'll see them and make sure that, okay, maybe we'll get some blood work and stool studies, or maybe they need directly admitted. And it saves that the ER, the burden of having people come that really maybe could be better served in the outpatient clinic. And the parents appreciate it as well, along with expediting any visits from our community pediatric providers who reach out saying that they have a really high suspicion for IBD. So we can get kids in on a timely manner, get them their endoscopies, and move on with therapy. Billy Melly and Colin Quinn are our two IBD nurse coordinators, and they have been doing a phenomenal job. Colin goes into the hospital when patients are newly diagnosed, gives them the face sheet, talks with them about who they contact after discharge, sets them up with their oriented IBD provider, along with assigning them their nurse. So before they leave, they know who to contact and why to contact before their appointment. Also, Billy comes with us to clinic and coordinates all the follow-ups, gets our patients consented for ICN. They disseminate all the information that we know as far as like our involvement with Camp Oasis. So kids are aware that we have a camp just for kids with ulcerative colitis and Crohn's disease, and that we encourage them to go. Talks with them about like IBD Unite, which is one of our patient education seminars we're doing on March 15th of this year with the Presby group, along with helping families really navigate insurance and specialty pharmacy issues, managing home infusions and all of our home injectables. I don't know when they sleep because they do a really phenomenal job. Additionally, Billy facilitates that final warm transfer and end of care dates for our young adults with IBD. Nick Knight and Bethany Nigra are our specialty prior auth specialists. They are phenomenal. And it's important, when I already highlighted that all of our medications are not FDA approved, having specialists that know the clinical data to supply along with the supporting literature to make sure that we have the highest success rate right out of the gate is imperative. They also are really timely with submitting those peer-to-peers and getting us scheduled, along with making sure we're timely in getting in those letters of medical necessity. Very kindly, of course. And then Roger Odom is our IBD Center ICN data analyst. And so I'll go into what Improved Care Now is in a little bit. So I'll talk more about him then. And then Michael Mathewson is our data entry clerk. This has been huge for our nurses. Before, they'd spend many, many hours transcribing all of the labs from our patients, because most of our kids aren't being seen at the main hospital or one of our satellites. They're getting labs in the community in a 2.5-hour radius from Pittsburgh. And when we're looking at our kids and we're trying to really acutely see what we need to do, we need to see those trends in our flow sheet. So she sits there and puts them in for us, which is awesome. And then additionally, we have our IBD-oriented surgeons, Dr. Mullen and Dr. Waltz, who have really been wonderful. Anytime there's a patient who has a surgical need or concern, all I have to do is shoot them a message and they make sure they see them in the next week or two. They have a wonderful bedside manner. And Kevin Mullen is known nationally and gives a lot of the talks at the IBD-oriented lectures and conferences. So we're really lucky to have him here at our center. I'm not going to talk long about this, but just showing a little bit about our IBD clinic, how we've revolutionized that. Before, we, again, used to see our IBD patients anywhere on our clinic schedule. Now it is an IBD-only template. So when they call central scheduling or they go on their app, you have to have a diagnosis of Crohn's disease or ulcerative colitis to be seen in our clinic. And then additionally, one day out of the week, all of the IBD providers, including Whitney Gray, are in the same physical location. So we're all in Lawrenceville on Tuesdays right now. And as of July, we'll be shifting to Monday to align with Dr. Mullen's schedule. But in that IBD clinic day, we're going to make sure we have a dietitian available in the clinic if we identify any malnutrition needs, that they're able to go in or just talk about the Mediterranean diet, which is something we recommend for all of our patients, regardless of dietary therapy. Also having a behavioral health specialist available to talk with all of our patients and making that part of the annual visit. So it destigmatizes it. Every single patient sees a behavioral health specialist once a year so that it is part of the care team. And really, in general, it's going to improve care. Right now, we don't have our behavioral health specialist identified. We are in the search, but we do have all of the funds and the support for that position. I'm hopeful by July that we have them hired. And then in addition, we have acute care slots built into our template, which really helps for our patients when they're flaring in the outpatient setting. Additionally, not only do we want to take all of our, make a comprehensive multidisciplinary clinic here at the main hospital, but we should be taking our care to the community. And so we've really designated outreach clinics to each of our IBD providers to making sure that it's accessible to those living further away from Pittsburgh. I go to the east, Dr. Crawford's going to be headed to the south, Whitney Gray Gray already goes to the north, and Nicole Davidson will also be going there. Additionally, Whitney Gray does virtual visits for her annual IBD visits, and this is really, really helpful, especially for patients being seen primarily by Dr. King up in Hammett, or anybody being seen in Harrisburg or living further than 2.5 hours from Pittsburgh. And so, in general, this is the model that we really are shooting to recreate. This was talked or spoken about last year by Hillary Michael, who was we were lucky enough to have come back and give our Kangos lecture. And really, we already have 3 of the 4 pieces to the puzzle. So we talk about Whitney Gray doing those transition readiness visits, and we start those at 12 years of age. Additionally, having the behavioral health specialist and the dietitian. And I've already highlighted the need for our multidisciplinary approach, including the behavioral health specialist and the dietitian. And I'm so grateful that our institution has been supportive. Our patients will already have benefited and will continue to benefit from this healthcare delivery model. However, IBD causes additional psychological and financial stress to the patient, which, in regards to patients missing school, parents missing work, high medication costs, long phone calls, and fighting with insurance. These stressors require a family to have to navigate a 504 plan, FMLA paperwork, secondary insurance, and a whole host of unforeseen financial and social dilemmas. A social worker is really essential for assisting the family in navigating these new waters, along with just providing financial and social support. It's hard for a patient to be compliant with their infusions if they don't have a way to get there. And so offering lift tickets or doing other things of that nature is imperative. So I do think one of the hesitations, and we all know this, involving social work involvement, is a concern for no billable services. After all, unfortunately, we have to have money. This is a business. However, we know that direct healthcare costs for patients with IBD is 3 times higher than those patients without IBD. And a multidisciplinary approach, including a social worker, when you look at patients with chronic disease such as IBD, has been shown to improve continuity of care, cost effectiveness of care, decrease of utilization of urgent or emergent care, as well as improve the health and quality of life of our patients. So if it's going to save our healthcare dollars, plus it's going to improve the quality of care, sounds like a no-brainer to me. And I would be remiss if we were talking about giving good care to patients without talking about Improve Care Now. So Improve Care Now is a collaborative learning health network that we're lucky to be a part of. So when it was first started, essentially they wanted to make guidelines for evaluation, diagnosis, and treatment of patients living with IBD. And it's made up of all pediatric IBD centers. When we see a patient, we fill out what we call an ICN Power form. The very first time we see them and we put in one of the form, they go into our database. And what we're filling out is what their diagnosis is, what their disease distribution is, any extraintestinal manifestations they may have, along with their activity at the time of the visit. And this is really important because this then serves for a way for us to data mine, do QI projects or retrospective reviews to see, are these guidelines we're putting out there actually effective, and are we taking truly good care of our patients? One of the really nice things that they came up with was the physician's global assessment. And I know that that's really small, and so I don't expect you to be able to read the writing on there, but really just highlighting the green, yellow, orange, and red being how the best way to really take the data that you have in that visit, along with their labs and their clinical findings and your physical assessment, and assign them an activity level. So are they quiescent or in good remission? Are they mild, moderate, or severe in their diagnosis? And so if a patient is coming to me in the office here in Pittsburgh or going to somebody else in Memphis, we're assigning that same activity, which really gives a cohesive way to be able to, when we're doing a retrospective chart review, that if I say they have mild disease, that's reproducible, along with the fact that they keep us nutritionally on track. It's one of those things where people think of a patient with Crohn's disease as a really skinny kid that's having trouble growing. But the reality is, with dysbiosis, we're seeing a lot more obese patients that are coming in with inflammatory bowel disease. So if a patient comes in and they weigh 100 kilos, you can't just look at the BMI and say, yes, there's no concern for any malnutrition. If they were 120 kilos 3 months ago, most definitely there's malnutrition and malabsorption. So it gives us additional ways to look and assess the risk of malnutrition in our patients, and making sure then we even have, a way to stratify and an algorithm to get them to our dietitians, and with what, in what urgency. Oh, I apologize. Additionally, we need to track this data. And so it's been a really nice way for us to see the different metrics that we're doing, such as steroid-free remission and whether or not our patients are in remission. Additionally, if they've not had a power form done within the last 200 days or 6 months, they go into a list that then alerts us and lets us know that they've not been seen, which is a really nice way in today's world to keep our finger on the pulse of what's going on with our patients and making sure that no one's falling through the cracks. And then population management, we do once monthly on a Friday meeting where we go over our patients that have been submitted through their power forms that have severe or moderate disease. And we go through these medically complex patients and offer any recommendations to the primary physician to make sure that they feel supported in their care. And so the nice thing to do is look at, well, are we making a difference? And it's really nice. So this picture on the left over here, I guess it would be your right, is a printout from October of 2024 showing that as a network, overall, we're having success and that 82% of our patients across the nation are in remission and 94% of them are growing well and 97% of them are off steroids. And these two charts here, I think it's really awesome to see both not only how we're doing as a center, but compared to other centers. In the last 2 years, we have increased our prednisone-free remission and overall remission and have actually been now outperforming the network as a whole that you see in red. So I think that was really, it's really powerful for our team to see that. You know, you're putting all the hard work in and really this is a nice way to see that it's going somewhere positive. And then in order to give good care, we have to have a good way to continue to define goals of therapy and what defines, what our goals are and what our goals of our medications should be. I mean, there's robust data that demonstrates that early treatment of IBD is critical to prevent complications. So starting therapy early is important. There's also been recent meta-analysis of Crohn's disease and clinical trials looking at real-world data that treatment with a biologic within the first 2 years of diagnosis was associated with higher rates of remission and mucosal healing compared to late or non-biologic treatment patients. So we need to make sure that we're starting therapy early and along the road, having different data points to be following and decide whether or not they're responding. Because if they're not, we need an exit strategy and we need to get to the next therapeutic. There's something that came out from STRIDE, which was a study done by adult GI colleagues, where they took a page out of rheumatology's book and they came up with something called treat to target. So our therapies, we need to know what the target of our care is. And for us in IBD, we made that mucosal healing. And mucosal healing means that after 6 to 9 months of our treatment, eventually we take another look. And when we look, we want it to be normal on endoscopy to the naked eye. So if you have Crohn's disease, no frank ulcerations, or if you have ulcerative colitis, we want that to be an endoscopic score of a Mayo 0 or no disease at all, or a Mayo 1 with just maybe some patchy redness. And overall, that's really revolutionized what we've been doing. And then STRIDE 2 came out later and showed, yes, this is actually improving care and more kids and more adults are under remission. However, along the way, we can't wait 6 to 9 months to figure out whether or not they're doing well. So here, and I apologize, I'll use my little laser pointer. Here, initially, you want to make sure that within a short time, our patients are responding. We're having less frequent stool. We're having less blood in the stool. And then looking at our CRP along with our fecal calprotectin, are those downtrending 3 months out into therapy? And are our patients clinically in remission in regards to their symptoms? And then finally, endoscopic healing. Are we seeing on repeat scope that our patients are doing well? And then, all of those are really trying to streamline the care we provide outpatient. But what about inpatient? As we all know, there's a lot of heterogeneity in how we do things, much to many residents' dismay when Friday comes and all the plans change for our patients. And, it's important for our patients' outcomes to have really streamlined care that's reproducible provider to provider. And so we started with an inpatient new diagnosis checklist. And this might seem really rudimentary, but I think it's imperative for good care. If you've been here for a week and your life has just been turned upside down because your child is newly diagnosed with Crohn's disease, the last thing you want is to have to come back to submit a stool study that we forgot to send off while you were here. Additionally, having our social worker consulted and getting you set up for secondary insurance so that you can afford the medications we've started you on. The second thing we also have streamlined is our acute severe ulcerative colitis care guidelines. We know that if our patients come in an acute severe ulcerative colitis flare, the risk for colectomy goes up exponentially. And so making sure that we're getting them the good care that they need. And if they're not responding, in the past, we used to give steroids, and maybe by day 3, maybe day 5, we felt they were responding. And we were using a lot of subjective data in order to gauge that. And then we would keep pushing the envelope till next thing you know, they've been on steroids for a week, still not responding till we finally move to the next therapeutic. This hastens that pace, or it gives us goal lines for our pediatric ulcerative colitis activity index, that if they're not having objective improvement in the number and their score, by day 3, you're moving on to the next therapeutic. It not only saves healthcare dollars because we're doing this in a better expedited manner, but we also are making sure that the patients, by the time, if they heaven forbid do go to colectomy, they haven't been on a week plus of steroids, they haven't tried multiple therapeutics, and have waited 2 weeks of worsening malnutrition, and we optimize their healing process afterwards, and we improve the morbidity and mortality postoperatively when we make sure that they're getting there at a more expedited rate. In regards to our patients with IBD, we know they have increased risk for clots, 6 times their age-matched peers, and that increases whenever they're in acute flare. So making sure we have a prophylaxis guidelines going on for DVTs. And so all of our patients should have SCDs on when they're in the hospital, and SCDs only work if they're on your legs. So making sure they're wearing them when they're in the bed, along with making sure they're on IV fluids. Any of our patients 12 and older in an acute flare, based on the new guidelines that Dr. Cooper came out with from hematology, they qualify for Lovenox, and that should be started in our patients. And then additionally, our stricturing disease. So Crohn's disease with strictures definitely lends itself to complications. And a surgery is always best done when it's done in a planned, secure fashion. When it's done in an urgent situation, it's more likely those patients are going to have an ostomy or have longer segments of their bowel removed, or just more scarring afterwards and more complications down the road. And so having a really structured approach to how we treat these patients is imperative. And Dr. Siebold, myself, Dr. Mullen, and Dr. Waltz right now are working on those guidelines. And so hopefully they'll be coming out soon. And then I'd be remiss if I didn't talk about transition and transfer. And this is not unique to IBD. Any chronic medical condition, transition and transfer is a really hard process. I mean, we all went into pediatrics because we love our kids, and then we have this longitudinal relationship. In the past, we used to, there was an arbitrary time that we transitioned them. Maybe they were getting married, or they were having a baby, or they just all of a sudden were 18 and you thought that was a good time. And in the past, we used to cut the proverbial cord and hope they landed in the adult world successfully. And in recent years, we really identified that these young adults, ages 18 to 22, are really vulnerable and a high risk for going off and having, not showing up in the adult world, having medication noncompliance, showing up in the ER for inappropriate, not urgent issues because they don't have a provider, or they finally show up in the adult world in an acute flare. And so we've really been focusing on making sure that we're taking care of these kids. Transition and care for our kids, we talk about this as a longitudinal process. I've already highlighted that Whitney Gray starts this at 12 years of age. And this is a consistent message that we're giving to our patients. So by the time of 22, they're not surprised that it's time to go to the adult world. And it's a lot easier of a conversation with the families because they've been preparing for this for years. And it's a longitudinal plan that's going to increase the amount of autonomy that the patients have over time, along with the fact that we're trying to, and I mean this in the kindest of ways, loosen the grip from the parents so that the parents feel like, okay, I've watched them in this close setting doing a really great job of managing their own care, and now I feel comfortable with them moving to the adult world. And so with that, we're hoping to really, instead of cutting the cord, building a bridge and allowing them, with all of the tools that we've given them, to cross over to the adult world for a really successful situation of setting up a new provider. And look how happy everyone is. And so I will say this, a transition program is only as powerful or successful as the buy-in from the adult program. And we're really lucky here in Pittsburgh that both of the health networks have wonderful IBD-related centers that are great coordinators of care with us, and really excited about partnering and getting our patients seen. They give us feedback as to how successful our patients were in getting seen, and making sure that they tell us that they actually showed up to that appointment they made. And that being said, of course, no good deed goes unpunished. As you all know, we have had some limited access, not just in IBD, but as a hospital system at a whole. And so we really had to start looking at our no-show rates and who was doing that. surprise, surprise, our 18 to 22-year-old patients, that vulnerable group that we've been really overextending ourselves to make sure we want to keep them here and we want to do them this solid, right? They were the ones with the last minute cancellations at the highest rates. And so, we were trying to brainstorm as to how we could decrease that. And we really looked inward and said, these resources are only as good if, as people know how to use them. And part of this is really our fault. We've not been telling them strict guidelines as to what we expect from them and setting standards as to what they should be doing in regards to the etiquette for cancellations, how often they need to be seen. And we need to really, truly give them guidelines in order to foster more autonomy. And so this resulted in our development of a code of conduct. We went and talked with our legal team, and we actually came up with a binding contract. And so what this talks about is what we expect from them. We want them to be getting seen every 6 months, and they need to show up to their visits. If they don't show 3 times, it's a reason for dismissal. And so we talk with them about, how you can call and set up an appointment, or call and cancel an appointment, or reschedule an appointment. Additionally, we gave them other guidelines for care, as to, making sure they're the ones communicating through the CHP portal, because at 18, they have to set that up, and we need to talk with them. Additionally, if they become pregnant or father a child, they do then have an expedited warm handoff to the adult world. When we discussed talking with the families about this, we were a little nervous. And so we kind of thought, how can we make this, and really express to the families that this is not us being difficult. This is us really, really wanting to continue to care for these kids, but make it feel that we just really wanted to give them and empower them to take more care of their own health and wellness. And so what we did was we turned this into an acceptance letter. And so we made IBD University, which is essentially they signed this acceptance letter, which is a legal binding contract saying, this is what we expect from you if you want to come to our university. And on their very last visit, they get a graduation certificate. And actually, they all really like it. And we already have enrolled 75 young adults, ages 18 through 22, and it has been really overwhelmingly well received. Moving on, I do want to talk about our diagnostic therapeutics that are diagnostic bowel ultrasound. I'm going to talk about bowel ultrasound. So it is something that is gaining traction in IBD. And actually, the United States and Canada are really late to the party. They've been using this a lot over in Europe, Asia, and in Australia to really assess how patients are doing with inflammatory bowel disease and looking non-invasively at their bowel wall thickness throughout their colon, along with whether or not they're having any stricturing in their ileum. And so you can see anywhere from the sigmoid colon following all the way proximally to the cecum and to the end of the ileum. I'm going to orient you here with my laser pointer. So here we're seeing a cross section through the colon, and this in the middle here, this hyperechoic area is the luminal fluid. And then what we talk about the Oreo sign. So here is the bowel wall between these two arrows, and the hypoechoic area down on the bottom, or the bottom part of the cookie, is the muscularis mucosa. The thin cream filling you see there, the hyperechoic lesion, area, is the submucosa. And then the top cookie is the muscularis propria. And looking there, we're able to calculate the thickness of the bowel wall. And the normal bowel wall thickness for adults is about 3 millimeters. And for pediatrics, we're seeing more so it's about 2.5 millimeters. And the really cool thing about this is we're able to predict with pretty good sensitivity and specificity whether or not our patients, if we did endoscope on them, we'd find endoscopic evidence of disease. And so in a patient visit, when they have a lot of symptoms and you're not sure, is this an overlap of their IBS, or should we really be concerned? If I order a fecal calprotectin, by the time somebody actually gets the stool sample collected and submitted, it takes 10 days to come back. And so 2 weeks later, you're calling the family and then talking with them about what the result is and what the next steps are. Versus if you throw a probe on them and in about 10 minutes, you can show them objective data that, no, actually doesn't look too inflamed. Let's still get the calprotectin, but I think we can hold off on ordering scopes, or, oh no, we're really inflamed. Let's get scopes and let's talk about your next therapeutic medication that we can do. Additionally, we're able to see hyperemia with Doppler, and so blood flow to the bowel. And that actually in pediatric studies within 2 weeks, that's the first thing to resolve. So it's a nice way that we can monitor and see early on without an invasive test if our kids are responding to therapy. Additionally, in our kids who have stricturing disease, oftentimes they end up having to get repeat MR enterographies. And I don't know if any of you have ever had one, but you have to drink about 2 liters of this not very palatable, almost like flat lemon lime pop, that then you have to lay still for 45 minutes, and afterwards it gives you terrible diarrhea. And almost all of my patients either vomit on the table eventually, or have terrible pain and diarrhea afterwards. So it is not a well-received study. And if we're able to do this in the office and save them an MR enterography, we can. This is never going to replace endoscopy and diagnosis and treatment of our IBD. We're always going to be using the gold standard of diagnosis with tissue biopsies, and we're always going to look for mucosal healing as our treat to target. But what this is really going to help us with is the interim, where we do this, we start the medication. Here, not only are we waiting for a CRP improvement and a fecal calprotectin improvement, we're able to see, are we seeing ultrasound evidence of improvement? For our patients on the inpatient service with acute severe ulcerative colitis, if we ultrasound them every single day from the start and they're starting their steroids, by day 3 of steroids, if the thickness of their bowel wall is getting worse, you wouldn't waste another 2 days with that algorithm and continuing steroids. You'd move on to your next therapeutic. So again, shortening hospital stays and improving the care we provide for our children. Additionally, we're hoping to have this here at Children's Hospital in the clinics by the fall of 2025. Dr. Rudolph has been kind enough to really help provide us with an IBD ultrasound for our group. And so we're working on getting that, but he has secured funding for that, which is really phenomenal. So thank you again, Jeff. Along with the fact that there's a specific training you have to do. So I'm lucky enough to be accepted to do that. I'm going to head out to Houston in March and then spend a month training hands-on doing ultrasound so that I can bring this for our kids. And then once we have this here, we can train our providers to continue to do this, and they can take a modified test without having to go through the 3 modules. Oh. All right. Additionally, as I talked about, that there's a paucity of data when it comes to real life research for our pediatric kids. And so research is imperative. I see Laura and Susan in the audience, and they are wonderful research coordinators, and they make this possible. Our team has been enrolled in many multi-center studies that has been continuing to move the needle forward in regards to what we know about kids with IBD, how they behave, and their response to our therapeutics. The first one we see is Cameo. So Cameo is a prospective study that we're doing for kids who likely have Crohn's disease. We get them consented before their scope. We collect their scope data, their biopsies from their scope, stool studies, along with the fact that we are really looking at the natural history of what they're doing. Right now, we quote in the early studies that infliximab has a 36% success rate. So you're telling me our best medicine that we have is only 36% successful. Clinically, that's not what we're seeing. And so this study really is imperative in saying the second arm or aim of the study is anybody started on anti-TNF, it follows along and to see what the success rate truly is and how many kids are going into remission. So that's going to be huge. NRN-UC is a study that's led here by our very own Kevin Mullen, and that's looking at NAD plus in ulcerative colitis and a way of stabilizing the mitochondria and as an adjunct therapy in ulcerative colitis. His research has really proven that there is a degree of mitochondriopathy that really perpetuates the inflammation in our kids with ulcerative colitis. So hoping that there's a nice adjunct therapy that can help us improve our therapeutics. Then CETON is another multi-center study that we're doing that's head by Jeremy Adler out of the Michigan group. And Aaron Crawford is going to be the head of that, the PI for our group. Dr. Mullen is the PI for surgery. And this is a really cool collaborative research study we're doing because right now, the way we approach perianal disease varies provider to provider and center to center. And right now, the first aim of this study is to look retrospectively who's been doing what are the patterns of behavior, and what's been successful. And then they're getting everybody together in a room, including the gastroenterologists, the surgeons, along with families. So we're having patients with perianal disease and parents, and they're coming up with guidelines as to how best to treat these patients, along with making sure that quality of life measures are taken into consideration. And eventually, it's going to be revolutionizing how we treat our patients with perianal disease. And she's going to be on the front of making sure that, we put out good guidelines and we're having good success. We also have Remodel CD, which is a study that we're getting off the ground around with our colleagues over at Cincinnati Children's. Phil Miner is the PI there. And what we're looking there is patients who are already diagnosed with Crohn's disease and on infliximab. We're looking at therapeutic drug monitoring and roadmap, which is a technology we use in the computer to kind of guesstimate with more success than me doing Half-Life in my head can for what we should be doing for dose and interval, making sure we're optimizing care. And hopefully that data will help us talk with insurance companies and make sure that everybody's getting coverage for their infliximab levels. Because at this time, you can only have a level and get therapeutic drug monitoring, which is supposed to be standard of care if it's approved by your insurance. Otherwise, it costs $700 to $1,000 per lab. And so it's really cost prohibitive for some families, and it leads to worsening inequality. And then compare. Compare is it's a Picari study that we're doing with Mike Kappelman out of UNC. And that is going to be looking at our patients who are failing our first line therapy of infliximab or adalimumab or anti-TNF therapy and going on to these secondary non-FDA approved medications and looking at the success, the efficacy, and the safety of those medications in our patients. So we can continue to move again the FDA forward and hopefully approving these medications for our patients and shortening the length of time to getting them on therapy. And then our future goals. So again, as this continues to rapidly evolve, it's really highlighted the need for formalized lectures and education and revamping the lectures that we used to give. And so Dr. Siebold and soon Nicole Davidson are tasked with really spearheading our formal lecture series for our for our GI fellows, along with our faculty. So we keep everybody up to date as to what's going on. Additionally, by the summer of 2026 or 2027, I'm hoping to have our first IBD fellowship year. This is something that's is gaining a lot of traction in the adult IBD world, as well as the bigger centers in the pediatric world, where we have a non-ACGME accredited IBD fellowship year, where we can have specific IBD training, along with, we have really nice partnership with our UPMC group over in Oakland. And so the IBD fellow would not only be able to go into specific IBD oriented clinics with the 3 providers and maybe 4 providers we have here someday, but they can also go over to the adult world and see a lot of the more therapeutic endoscopy that's going on and other, and also get trained in bowel ultrasound here and get accredited. So I think that's going to be really exciting. And additionally, I want to continue to just grow our team. We have a really, really wonderful, as I already mentioned, dedicated team. We have a really nice culture amongst our group, and I want to continue to grow that team in order to better serve our growing population. So with that, I thank you so much for being here and thank you for listening, and I open it up for any questions.